There we go. So, Dr. Saifuddin, I was thanking you for your feedback. And very honestly, I read everybody's feedback very, very carefully. I try to understand where I have been able to meet your expectations or where I have failed to meet your expectations, so that I must, make sure that you go satisfied with the program. And I read that you said, had there been PPT, it would have been really nice. And very honestly, I had the PPT with me, but because of the shortage of time, I had to skip it. But then I thought, no, I must add it because that's required. And that's one skill I really want all of you to go back, very equipped with, because it's personally also very empowering to learn assertion and, practice it, because it comes with a lot of practice. So we'll be spending initial 30 minutes on doing a small exercise on understanding what is assertive communication. And then I'll be sharing the presentation with you. And then we'll cover the topic hands-off in clinical communication. And then we'll have two presentations by Dr. Rajesh Pai and Pooja. I think both of them have done a lot of, effort. They made a lot of efforts to do it in a very meticulous manner. I'm very happy the way all of you are taking it very seriously and working on it. Okay, so I think two participants haven't yet joined, Dr. Pinky Yadav and Captain Sandhya. Can somebody message in the group asking them to join? Okay, so all of you have your scores with you, your communication style scores with you. Is it handy? Is it handy? So do you remember at least the 4 communication styles we discussed? Can you type in the chat box what 4 communication styles we discussed? Please type in the chat box the 4 communication styles we discussed. Okay, assertive, aggressive, passive. Very good, passive aggressive. Very nice. So that means you remember the 4 communication styles we discussed: passive, passive aggressive, aggressive, and assertive. So just to kind of revise and understand, do really understand these terms in real sense, I'm going to do a small activity with you, and that is rapid fire round. So I'm going to give you a statement, and you will have to write in the chat box what do you think that what kind of communication it is. So give me a second to start with the questions, and you will have to write in the chat box. Nobody listens to me. So what do you think it is? Is it assertive communication, or it is whatever it is? Write in the chat box. Very good. Passive. Excellent. It is difficult to explain the patient or patients. It is difficult to explain the patients. Is it passive or passive aggressive? Because there is resentment. When you make a statement like this, that nobody understands, people are not wanting to understand. So it's not passive. Passive is where you don't have any, you have already given up, you have given in. So we need to also understand what do we mean by given up and giving in. And that's what exactly happens when we are, talking to people or talking about people. So, okay, rich patients are spoiled brats. Rich patients are spoiled brats. So is it passive, passive aggressive, aggressive? Okay, Reena says it is aggressive. What do others say? Aggressive, aggressive, passive aggressive. Yes, Dr. Anup, it is passive aggressive. There is resentment. See, whenever there is a resentment in whatever verbal communication we make, or non-verbal communication we make, that shows that there is an aggression in the background. We may not speak very, honestly about it, but then there is a resentment at the background. There is no point arguing with the patient. It is better to agree to whatever they say. What do everybody say? There is no point arguing with the patient. Yes, passive. Passive. That means you have already given in. You have already given into that pressure. It could be even passive aggressive. If you explain to a patient, they would understand. Assertive. Very right. Assertive. Agreed. Completely agree. Okay. When the patient is in pain, they will have difficulty understanding others' point of view. Assertive. Very right. Assertive. Completely agree. Okay. There is no point explaining your point of view to the patient. It does not help. Passive aggressive. Very right. Passive aggressive. Very right. It is important to show patients their place. It is important to show patients their place. Aggressive. Absolutely right. Aggressive. Correct. Very right. If you are nice to patients, they are likely to demand more services. Passive aggressive. I completely agree with all of it. It is important to raise your voice to show patients their position. Aggressive and passive aggressive, both would be fine. But then there is a resentment, there's aggression in the background. How much ever upset you are, we should try to behave well with patients. Assertive. Wonderful. So we are getting the background feeling. It is impossible to deal with people who have a short temper. It is not assertive. It is passive or passive aggressive, that you have already taken it for granted that people who have short temper, it's difficult to deal with them. Most of the times patients do not want to listen and they just want to act demanding. Again, it is passive aggressive. It's a presumed thought. There's already a resentment. There's already a thought process that nothing is going to work and these people are not going to listen to me. In case the patient misbehaves, it is important to show them their place. Aggressive, outright aggressive. Agreed completely. In case, it is obvious to get angry if the patient is misbehaving. Again, aggressive. Absolutely right. Aggressive. I completely agree with you. Most of the patients do not know much, but they argue baselessly. There is resentment. There's already a presumed thought behind it. Okay. There can be a difference of opinion between two people, but that does not mean that they get upset with each other or start fighting. Assertive. Absolutely right. Assertive. There's a possibility that the patient may not understand our point of view, but instead of losing our patience, we should try to explain to them our perspective. Assertive. Absolutely right. And the last one, if we explain things in an amicable manner, we can calm down anybody. Wonderful. So congratulations. I think most of you have done very well. That shows that you have a lot of clarity on it. This is what I was expecting, that you See, these are the common thoughts we all create. This is the usual way we look at situations and people. But if we are mindful of from where it is coming, then you will find it. Then you will find it easy to change your way of looking at situation. So once you know it is passive aggressive or it is passive or it is aggressive, definitely you will work on it. Till now we were in slumber. We didn't know, oh, this is a negative thought or it's a passive aggressive thought. So we were just thinking the way we were thinking. So this process is called metacognition. Metacognition is when you are thinking about your thinking or your way of thinking. And assertive communication is a learned communication style. It would only come if you frequently indulge into metacognition. If you frequently analyze your own way of thinking, feeling, and behaving. It's a learned process, but it is not impossible. And it's a beautiful process. It's very empowering because you're trying to check your own thought process, your own feelings. And then now you will work on how do I change it? Because if it is not healthy and if it is counterproductive, then it's not required. It's not helpful. It's going to damage you as a person more than anybody else. So
Ma'am, it is pardon?
Metacognition.
Cognition.
Cognition, yeah. Should I write in the chat box? I'll write. Metacognition. So it is like thinking of what I'm thinking or how I am thinking. So as a third person, now you're evaluating your own way of thinking. So, but I'm very happy that you have a lot of clarity on it. Taking it further, I'm going to share a presentation with you. It's specifically on what exactly we mean by assertive communication style and how it is beneficial and how do you really apply it in real life situation. So let me quickly share the screen with all of you and share the presentation with you. Okay, so this is how we usually express our disagreement. Either we get angry, or if you look at the picture on the right side, we normally become very quiet and sad, but we do not make our point, or we, even after trying, if we have failed, we kind of take a stand where we say, okay, I give in and I'm not like kind of going to take it further. Another way is where people, they are annoyed inside, but they'll try to, cover up by expressing their unhappiness in different ways. So if you look at the gentleman's expressions, so maybe you don't know whether he is happy or unhappy inside, but then he's trying to resolve the situation by pleading her. And if you look at the lady's facial expression, she's unhappy, but she's not addressing it. She's not kind of dealing with it. Another way which we use is when we become actively aggressive. So you can see both the partners are shouting at each other to the highest pitch and tone. And obviously, we all know that these kind of ways of expressing our angers do not take us anywhere. They are counterproductive. Again, they are unhelpful. This is another way you often see when people don't say anything verbally, but non-verbally, they sabotage, they don't cooperate, they are not helpful, they are not giving their 100% to the place of situation, and they're always critical of your way of, working or acting. So we often see even this behavior among people. Again, that's not a very desirable way of expressing or hiding our emotions. So there is a right way of doing it, and that's what we are talking about, and that's called assertion. So assertion is all about, talking about your needs and others' needs as well. See, normally when you are occupied with your needs and when you are particularly uh, um, uh, very strong about your needs, then you're likely to become aggressive. So where you think what I'm saying or doing is the right way of doing it, so you are likely to be aggressive. On the other side, if you're more, caring for others' need, but you give in or give up your needs, then you're likely to be passive or passive aggressive, because that's where you don't care for your needs, but you are primarily trying to serve others' needs. And that's what we see in the healthcare system. You will see people who are in a position where they can use their aggression to control others. So they will just be very demanding and ordering, authoritative, dictating others to follow their instruction. You will also see people in healthcare who just quietly be following others' instructions, not saying anything, not giving their viewpoint, not sharing their thoughts. Internally, they may be unhappy, they may be happy, they may be quiet, they may be dissatisfied, but they would not raise that issue. But the right way of communicating, or having a healthy relationship is where both the parties, assert and address theirs and each other's needs in a sensible manner. So we normally say people are difficult. There's a saying, people are not difficult. It's only because we do not know how to deal with them and we think they are not manageable. But if you learn the right way of dealing with difficult situations, I think you can deal with those situations and people in a more impactful manner. So their assertive skills will come handy. So what is assertive skill and how do you really apply it? Let's understand it. For example, assertive skills will bring in objectivity, or you can put it the other way. Actually, you have to be very objective when you are assertive. So there will be a situation, people will come shouting and arguing with you. If I take Pooja's example, what she shared last time, that she was taking around in her ward, and there was a patient who was, patient's attendant who was very aggressive, very dissatisfied, and was shouting and fighting with the nurses. Now, there is one thing, that is his behavior, that is the emotions he's expressing, and the problem he had. So if you want to practice assertion skills, I think we have to deliberately learn where we need to segregate two things, emotion from the problem. So focus on the problem and not on the emotion. So behavior can be rude, angry, crying, aggressive. For a minute, if you can put that aside and look at the problem, you will be able to deal with this situation in a more sensible manner. So there's a very good way to really, calm down the emotions or settle the emotions and park them on a side. That is called use validation skills to handle others' emotion. For example, if somebody has come shouting and is very annoyed and is doubtful that you have done something wrong to me, rather than saying, how can you say this? What proof do you have? I think you don't even know what is the reality and you're just shouting. I would say, I can see you're very angry. I can see you're very upset, but let me understand what is your concern. So I'm validating his emotions. I'm validating his state of mind. Validation is not that I agree with you, but it is acknowledging. A lot of time when you validate other person's emotional state of mind, it brings calmness in their approach. So validation is a very good way to acknowledge the other person's state of mind or emotions, and that will, create a dialogue between you and your the other party. So you're not necessarily agreeing to the person, but you are understanding, or you're trying to understand the other person's point of view. So for example, when you make a statement like this, I can see that this is very upsetting, and from your perspective, I can see why. For example, that patient's attendant who said that this medicine is given to patients who have an heart ailment. How can you give this to my mother or my father who doesn't have any heart disease? So anybody will be upset if you get to know that your family member is getting a medicine that the person should not be taking or can do a harm. So his being upset is quite justified from his perspective. So when you make a statement like this, it tells them it's all right, I completely understand. But then you don't elaborate on it, or you don't take it further. And there you say, let me see how we can manage it. Okay, what can we make to make this situation better for both of us? So now you're taking the person's attention to the issue rather than the emotions. But just validating is enough to address the emotions at that point of time, rather than arguing or kind of condemning his emotional reaction. What is there to be so angry? But I don't think it's such a big thing the way you're making a chaos out of it. I mean, you can't disturb the decorum of this place. That's not going to help. So just validating emotions is enough, and then you can, take your attention to the problem and work on it. Sometimes they would criticize your system or your staff or your services. Accepting the criticism is one of the best ways to start with. So when you're accepting their criticism, not that you are accepting it as it is, but then you are telling them that I'm taking your criticism as feedback and not as an attack. The moment you react to it, that means you're taking it as an attack. So the first thing that we need to do is listen to their point of view. Even if you don't agree, if you lend them an ear, if you listen to them patiently, and you demonstrate that, yes, I'm listening to you attentively and I'm trying to understand your point of view, even that is enough. And also, please remember, whenever a criticism comes, there's always a feedback. It could be misunderstanding. It could be a communication gap. But even that gap needs to be fulfilled from our point of view. So therefore, we have to take that criticism as a feedback and see how we can make it better next time. Then if the patient or the attendant is giving you some feedback and half of it is truth and half of it is not true, so acknowledge the true facts. You can't say what you're saying is bullshit. It's not. So if I say, I completely understand your point of view, I mean, if you get to feel that your father is getting a medicine that he's not supposed to be taking, it's perfectly fine the way you are feeling. So you're acknowledging the true fact. But let me find out what is the truth. So you are not agreeing to the whole thing, but you are saying, let me find out the truth. So there you are acknowledging what is truth, but you are not agreeing to the whole statement. In case there is an error, in case if there's a mistake on our end, I think acknowledging and accepting is the best way to start with. The moment you acknowledge, I completely understand. I think there has been some, confusion. There's some confusion at our end. Let me find out, please. Give me a little time. Let me find. So what you're saying, you're acknowledging and you are kind of agreeing to taking a corrective action. So if the criticism is not true, acknowledge the statement or the feedback expressed by the individual and then state your belief or interpretation or provide additional facts. I'll give you another example. For example, a patient attendant comes to you and says that nobody is looking my father in the ICU. Every time I go to see my father, he's lying alone. There's no doctor, there's no nurse around the patient. Oh, I don't know what you're doing. There's no change in his condition. I'm not satisfied with your services. So he's made a huge statement about the services, about the way we are functioning, about probably the way his father is being looked after, about the care the patient is getting. So half of it could be true, half of it could be wrong. So when you say, I understand that you're concerned about your father's condition, but when you make a statement like this, that there is nobody looking after my parent, I must inform you that ICU is the only place where we always have doctors 24/7. Or when you say in the ICU, the nurse-patient ratio is 1:1. We make sure that every patient has a nurse. That is why it is called critical care area. But our way of monitoring is modernized. Now we have monitors. We are always, monitoring the vital signs of the patients, where the patient's heart rate, respiration, blood pressure, SpO2, everything is displayed, and we have set up an alarm. The moment it goes down beyond a point, it alarms. So we immediately go and see what's gone wrong. So please don't get perturbed about the idea that we are not attending to your father. So what you have done, you have acknowledged his statement, you have tried to address his concern, but you are also giving your clarification in a scientific manner by providing additional facts. Owning is another way to handle people who have come with disagreement with you. So sometimes when they say something which may be true, like for example, if a patient comes to you in the OPD and you are OPD manager, I think Dr. Pinky has joined another link. So can somebody message in the group by telling which link they have to join? Thank you so much. Thank you. Thank you. So Yes, now I think. Okay. So sometimes, like for example, if the patient has been waiting in the waiting area in the OPD for almost say 1 hour, much beyond the expected waiting time, and he's come back to you very agitated, and he says, I mean, you have a useless OPD system. People are just, waiting here and you're not doing anything. So that means the person is pointing out to maybe a system failure or maybe a situational failure. So sometimes owning also helps. Sir, I completely agree. The OPD is very heavy today. It was actually, we had 2-3 days holidays and the OPD was not fully functioning. So probably all those patients who were waiting for last couple of days have come today. And that's why there's a huge rush. So you are owning the problem. You're owning the situation. So even that calms down. That also, calms down. And sometimes, perspectives are hard to change. Even if you try to change their perspective, it may not help. But just owning will also kind of give them discomfort that, okay, you're accepting what is happening in your system. So persistence, that means if you do not agree with the other person's point of view, or if you are trying to make a point, we don't have to become defensive or get distracted. For example, if the person has come to you for discount or for reduction in the bill, now his agenda is to create ruckus or maybe to shout or to degrade or demean your services to get the benefit of getting the discount from you. So you can very well see the hidden agenda in this. But if you stay focused, you say, sir, I think you have seen our services. We have talked to you a number of times. We have updated you about the expenditure. We have always given you an estimate of what is expected, in this kind of a setup. But this is the maximum I can offer you. So that means you are staying focused on the issue rather than being distracted or getting defensive or starting to justify your services. A lot of time people will try to play games with you and try to overwhelm you with emotions. But that's where your persistence will come, and you need to, I'll give you a couple of examples how you really handle these situations, and then repeat the bottom line to keep the conversation on track, where you say, I completely understand your concern, but however, this is what is in my hand, this is what I can offer you. So you are persisting on your point, and that's another way of asserting. Sometimes even challenging the false information is another good way of asserting. Sometimes people will come and give you a feedback or a point which doesn't hold any truth, and people will try to use that to overwhelm you or to destabilize you. So that is just to escalate emotions and upset you. So sometimes it's important to ask for evidence. I have been waiting for 2 hours. I've been waiting. And this patient came just 10-15 minutes before. So let me check. Can I see what time you came in? Or sometimes when patients say, or patients' family say, you don't upset, you don't update, you don't inform, you don't talk to us, you don't you involve us in anything. So you say, we have, twice in a day we meet the patients' families, and we write in the case file, and I can show you the case file, and this is where we note down whom we have met. So either you are asking for evidence or you are giving an evidence to challenge the false information. So their documentation is a big thing that would come handy to help you. But when you ask for evidence, you people are careless. So you're making a very huge statement by saying that you people are careless. Can you give me some more details to kind of tell me what exactly you mean by you people are careless? Trust me, person will not be able to hold any ground. So if they say something and there is a grain of truth, validate it. But in case when you ask for evidence and if the patient or the attendant has nothing to say, most likely they will understand that they were just making a generalized statement and it was not true. So this is another way of handling the situation. Okay. At times people are rigid and they are and there you need a more forceful stand, to deal with that situation. So when people are not ready to change their point of view with your explanation or with your discussion, even something like this, uh, I'm really sorry. I simply don't see the way you look at it, but you are more than entitled to your opinion. Healthcare professionals are cheap. All corporate hospitals are here to make money. So that, and you try to explain, sir, everything is very, very, very expensive. If we want to give you quality services, then we need to hire enough number of people, then we require latest equipment, then we require on the, around the clock, we require, security and all other services. So naturally that comes with the cost. No, 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 no. You people just try to justify your, expenditure, but that's not true. So you have done your enough, discussion and explanation, and you see this person is not budging. So there, when you are able to say, I completely understand. You are free to have your opinion, although I don't agree with it. But then I think I would not argue further to change your opinion. So that's another way to, handle a situation. Then again, when you are disagreeing, make sure that you use factual information to disagree. So when you'll have factual information to disagree with the person, naturally the person will feel that what you're talking is not just in ear, but also you have a evidence to showcase. So actually, for example, if the person says that you were the one whom I talked to, and you say, sorry, I was at another place, so it couldn't have been me, it could be some other person. So that's how you can actually, show them the evidence. Okay. Then sometimes even pumping the negatives is a good way to handle, people who do not agree with you. So what is pumping the negative? Can somebody guess? What do we mean by pumping the negatives?
Hi, good evening, ma'am. Dr. Pinky
Yes.
this side.
Very good evening. Very good evening.
Sorry, I joined late.
We miss you. We miss your presence more than anything else.
So pumping the negative, I would say, is, sometimes, the patient will come very aggressively and say, कि ये बिल्कुल गलत है जो हुआ. मैंने कहा बिल्कुल गलत. मैं भी यही बोलती हूँ. मैं बोला हाँ बिल्कुल गलत है. जो आपके साथ हुआ वो मेरे साथ भी होता तो गलत है. I mean, that's how you start, and then he's kind of, they don't expect that kind of reaction, and then they sit down and calm down, and so sometimes it works, sometimes it doesn't.
Yeah, exactly. So you have to actually, very eclectically, you have to choose what will work in what situation. Yeah. So I'm trying to give you the options that you can use to handle those situations. Dr. Anuradha, you wanted to say something. You rose your hand. So please go ahead.
Yes, Dr. Indu, same thing I wanted to say. When somebody says something, we say, yes, I fully agree with you. This is what is happening in this corporate world. This is what is, but then you have to give the factual information to then, pacify them a little bit and then convince them fully.
Wonderful. So I'll just add one point here. So pumping the negative means, I'll say, I think you are right. I think the general way, this is how people are handling. So can you tell me what exactly happened with you that made you think like this? So again, you are asking for more evidence. Then probably the person will have maybe a point or two to tell, which you can address amicably. But then when you're pumping the negative, you are first aligning with the person, but then also making the person feel, I think you are making a big issue of a small thing. That initially, just to align the person, you are kind of, pumping the negative. Okay. So pumping the negative is ask for more negative feedback, but in an assertive manner, as though you're trying to learn more about how to do better in that area. So what do you think can be done to handle it? Do you suggest something? So that story, if you remember, a very famous painter. Who was that painter? Do anybody remember? I'm forgetting the name of the painter. He put a beautiful painting in the crossroad, and he asked, he put a note with the painting, please tell me what is wrong with this painting. So next day when he came back, everybody had circled one or the other part of the painting, saying nose is not right, eyes are not equal, the lips are not looking very, well painted, the ear size is very abnormally small. He was very upset. He thinks this was not this bad the way people are criticizing. So he put another painting next day and he said, please correct whatever is not okay. So there was not even a single correction. So when you say, okay, what do you suggest? What do you think can be done to deal with this? What do you think will help you here? Then you are probably giving them a chance to introspect that, okay, I mean, what I'm saying is true, but then it's not always in their control. Then, so when you are pumping negative, please pump practical negatives and not the baseless criticism, because that would not help you solve the problem. So you are genuinely asking, tell me, how can we make it better? Can you suggest some ideas how we can make it better? Humor. How many of you use humor to handle a situation? Has anybody ever tried? Has anybody ever tried?
It's
Yes,
very
ma'am.
risky, madam.
Sorry?
That is very risky. Huh?
Very risky. I completely agree. Using humor is very risky unless you are in a position where you can manage.
Yeah.
It's very risky. I completely agree with you. But has anybody ever tried? No.
Ma'am, I have tried, but not with the patient, ma'am. It's with my senior.
It's all right. Okay. So share your experience. Tell me what did you try?
Yeah, ma'am. Actually, we are from nursing education department. So she just called in the morning. Maybe some incidents has happened last day. So she was just calling us, means to scold us only. So when I entered, I thought what to do, because it's early morning, and if we are getting scolding, then whole day is going to get spoiled. So I just went inside and I just, ma'am, you are looking very fresh and beautiful today. And then she was in anger and she smiled. And then she forgot to scold us. Yes, she told about the incidents, but the way actually the intensity of that shouting, it was down.
Wonderful, wonderful. So complimenting is another good way to make the person feel better and change the emotional milieu. Very right, Pooja, very right. You have added another. Yeah,
I remember I have tried this complimenting on patients. Somebody is like very aggressive, very angry. So, oh my God, are you a patient? You don't look like one. कैसे admit हुए आप? आप तो बिल्कुल ठीक हो. Okay, and you're so pretty. तो जितना aggression, especially the ladies, so अगर वो गुस्सा होती हैं, ये sister ने ऐसा किया, उन्होंने देखा नहीं and all, तो वो भूल जाती हैं, oh thank you so much, and then it goes on in a good way. So complimenting is really important.
Wonderful. So I'll share two experiences with you, but that might help both of you. I remember he's a friend of my husband. He's a bariatric surgeon. Many of you may be knowing Dr. Praveen Bhatia. You know him. He's my husband's batchmate. So they're a very good friend of mine. So he would use a lot of humor with patients, but he's very smart at using humor. Very smart at using humor. So he has a habit, please don't quote me. He would go to the OT and make his patients wait in the OPD. Very often he does this. And after he comes back, a lot of time patients are very agitated, but he knows how to, lighten the environment. So he would say, one day in my presence, this happened. So this patient was very furious. He said, Doctor साहब, अगर आपको 3 घंटे बाद आना था, तो मुझे 3 घंटे बाद ही बुलाना था ना. Dr. Bala, did you understand? No. I will repeat. So this patient was waiting for almost good 2-3 hours in the OPD, and Dr. Bhatia was in the OT. And the moment he came out from the OT, the patient literally was very aggressive, and he shouted at Dr. Bhatia, if you had to go to the OPD, why did you call me? I'm waiting for the last 3 hours. Dr. Bhatia, in a very, very stylish, smart style, he said, you have waited for 3 hours for me. I have waited 20 years for you to come here. And trust me, he is very smart at using humor. I see him very often, very often. He's a man to be met. I was thinking I'd involve me as a speaker in one of the programs. Very smart, very smart. Other experience that I can share with you, between husband and wife, a lot of time we would have argument and we fight and it goes on and we know it's not going to do anything. We are just taking out our anger. And sometimes even our children say it's like Tom and Jerry show we every day see, and then every second minute you both of you are very fine with each other and you can't live without each other. By the way, ours is a love marriage, and I'll share my love story sometimes later. So both of us have learned that sometimes it goes to a point where we think, what are we doing? It's a pointless thing what we are doing. So very smartly, unknowingly, we both have learned that one of us will say something that will be a little humorous. The other person, instead of getting angry that how can you make fun of it? Is there anything funny about it? The other person immediately picks that too, that this is the stop button. And the other person would laugh. And we end the argument. I think this is one way I use very often, like we husband, wife, we both use it very often, because I know we at times, argue unnecessary. And at the end we realize, what are we doing? He's right on his point of view, I'm right from my point of view. But we keep arguing to prove our point. Acha, you do it. Okay, you're the boss. This is your turn now. You would say sometimes to me, this is your turn now. You take the lead. Next is my chance. And then we know we have to end it. So I can tell you this is a wonderful way to handle sometimes personal arguments where you're just dragging a point and it's pointless. Do you think that will help? So you, at least in your personal life, you can try this. Dr. Sandhya Shankar, we haven't seen your beautiful face. You need to really have your camera on. And Dr. Sandhya, are you there? Captain Sandhya, are you there? You are missing classes. Those who are missing classes, they will be made to attend the next batch. And only then they will get their certificate. I am not going to give you the certificate till you have attended all the classes.
That is,
I know you all are very
that is assertive. Madam, that is assertive, aggressive behavior.
And using humor. And using humor. So if you want your certificate, you will all have to attend you will have to check your attendance and tell me which all sessions you have missed so that you attend the next sessions and complete your. So that was just in a fun way, but I know you all are occupied, busy, and you have a number of other responsibilities. I think we are just left with 3 more sessions. Today's 8th, no, only 2 more sessions. So if you can make sure that you attend both the sessions, it will be really nice. And I've rather reduced the frequencies just once in a week. We can even change the day in case if you think Friday is not suitable to all of you. Yeah. So you can tell me today we can.
If it is Wednesday, Thursday, I think it will be better because weekdays are normally weekends are occupied.
So we can keep Thursday if everybody agrees.
It is agreeable to everyone.
Ma'am, sorry, Sandhya pitching in. Working days are not working at all for me, and that's the reason I'm struggling with my this participation. But I'll go with the majority and I'll manage them.
We miss you, Dr. Sandhya. We miss
I miss too. Believe me, I'm really missing being here. Thank you.
So using humor is a wonderful way to break negative emotions. Only thing is you need to be really, really good at it. Humor can put tense situation at ease, but you need to know this, see the sensitivity of the situation. And I think we are all very intelligent that way. I don't think in any serious situation when the patient is critical or it's a completely aggressive situation, we would use humor. But humor can be tried in moderate to low moderate intensity situations where you can use humor. I would suggest if you want to use this in your future interactions, first try at home. And then second, try with your juniors. which is a safe place. Because initially it requires, the knack of doing it. So try doing it at home, which is very safe. Even if it misfires, it's all right. Do it with your juniors. Again, it will rather build rapport with your juniors and also give you a chance to handle the situation. And if you are good at it, then you can use it anywhere. And then, of course, when the grain of truth is found, which is true, you can sometimes joke about it while owning it. I know it must have been really very, very, very painful for you to have waited for me for 2 hours. But it's all right. Sometimes we all have our turn. Maybe you can make me wait the other time and you end it there. But you have to be careful when you are using humor because, professionally, personally, you really need to have a knack of doing it. So I'm giving you some of the examples of assertive communication. For example, when we say, you never let me complete. So when you're asserting, rather than using general statement like this, it's a good idea to say, can you please allow me to complete? We say this too very often. You don't let me speak. You always interrupt me, especially in our personal conversations when we are interacting with equals. You always interrupt me. You never let me speak. So that's more like generalized kind of a statement. Instead, if you say, can you allow me to complete? Sometimes we say, you didn't give me time. You did not give me the instructions on time. And that's why I could not do it. Rather than saying like this, if you say, I'm really getting delayed in making the plan of work since I don't have the clear instructions yet. It'll be really nice if you give me in time. I can be ready with my work. Or when sometimes we say in anger, you don't let me present my work completely during meetings. You interrupt and you take the lead and you just start talking and you don't let me complete. So again, instead of saying like this, if you say, I feel frustrated during meetings with you because you don't let me present my work. I would like to do a complete presentation so that I could provide my valuable inputs. After my presentation, you can give your point of view, but I request you to allow me to complete my presentation. Working in this place is impossible. None of the departments are doing their work properly and the whole place is falling apart. Again, it's a more generalized kind of a statement. It will not take us anywhere. Instead, if we say, I find it really difficult working here. I think that something needs to be done. And if that's not done, I'm worried about the future of this organization. So some of the starting, statements like, so what you're saying is that this place is not good for you. So you're kind of rephrasing. That's another good way of asserting when you want to confirm the bone of contention. I can see that this point is important to you and it's also important to me. Perhaps we can talk more respectfully and try to solve the problem. Again, you're validating, you're acknowledging, and you're inviting the person to come to the table and discuss it. And when you use words like I think, I feel, I believe, I statements are a wonderful way to assert. Use it more often. It will add impact to your communication. I would appreciate if you explain this further or if you tell me more about it. Again, you are appreciating, so you are calming down the person. You are inviting the person to tell more. Let us see how we can find a suitable solution. So when you use let us, it really helps in making the person feel that you want to work as a team. We have a habit of accusing people. You have done it. You have done it. Let us see how we can make it better. Let us see how we can resolve it. So this term really helps in bringing the person to the table and resolving the conflict. So quickly to summarize, I think every time we decide to communicate, we select a style of communication. All of you have taken that questionnaire. You have an idea about your primary communication style. Notice your and notice others also. You'll get an idea what is other person's approach. Assertiveness allows you to face confrontation in a healthy way without getting overly emotional about the situation. Usually it is the emotions that hijack the situation and things go out of control. If you can manage your emotions and if you can manage the other person's emotions, you can handle any situation. Benefit of assertive communication is there is no accumulated anger. So when you are able to express your thoughts in a legitimate manner, you are more likely to be satisfied with the way you had the discussion. It's a better and it is better and it brings in better and transparent relationships because you have been able to talk one-on-one with the person rather than hiding your emotions, thoughts, or feelings. Then when you assert, others take your opinion seriously because you have been able to speak your mind and heart in a very clear manner. You earn respect and credibility because you, even if you want to say something harsh, but you chose a right way of saying that, it earns you respect and credibility. It also reduces the risk of exploitation and abuse, especially for those who have a tendency to go into passive and passive-aggressive kind of communication style. So it's really helpful in reducing the risk of exploitation and abuse. And life becomes easy and stress-free when you start asserting in your personal and professional relationships. Thank you. So this was about assertive communication. Any questions about it before we move on to the next topic? Yes, Dr. Anuradha, please.
We talked about validation.
Yeah.
Doesn't validation make them feel that what they are saying is correct when they are using, wrong statements for the topic going on or to the facts? So if we validate as a doctor or as a senior person in the corporate or wherever we are posted, doesn't it make them feel that what they are saying is correct? They can hold on to that?
Validation of emotion, but not validation of the thoughts. Anybody would be upset if that person was made to wait for 2 hours. You are validating the emotion. But however, sometimes things are not in our control. Today we opened the OPD after 3 days of holidays. So there's huge rush. Kindly bear with us. I'll see what I can do to help you best. So what I have done, I have validated, but I have given my reason, which is quite justifiable. I'm not saying OPDs are very heavy here. You will have to wait. There's no way out. That's what we normally say. Sir, OPD mein to itna time lagta hai. That's something, that's our failure, our system failure. If I'm not valuing my patient's time, that's my system failure. But if I'm giving a reason that is situational, justifiable, and you think will
So
be...
basically validation works with... So validation works mainly with the emotion. Rest of the things?
Yeah.
Okay.
You are not, and you are not even agreeing with the point of view. No. If you saw the presentation, I said you are validating the emotion, not necessarily you're agreeing with the emotion. Validation gives the person this feeling that you are able to understand my state of feelings. Any other question?
Thank you, ma'am.
Any other question? Dr. Saifuddin, anything you wish to say or ask?
Right now, no, nothing from us.
That's all right. Dr. Leah, anything you wish to comment or ask? We move on to the next topic.
No, ma'am. Nothing right now.
So we move on to the next
Madam,
topic. Yes, sir. Please.
One point. Yeah. One point we always noticed is that aggressive behavior many times is shown by a new bystander who has come on the last day of when the patient has died or patient has become critical. We may have the bystander who has been there since the beginning with the patient. I'm just talking about a critical care patient. The patient bystander who's been there for a long time knows that the patient is in a bad shape, and we have been explaining to them all these things, and they never get angry. But the new person, he has another objective. He wants to show that he is very, he can, he has got the power to, bring the systems under his control, or show off in front of the institution. So like that, they do sort of a drama. That is where so many of these fights occur. They have no idea what we have done, what we have taught, what we have communicated. That is one experience I'm just sharing.
I completely agree with you. Although this we're going to deal in detail when we talk about breaking bad news. Okay? But I want to address this question right here. See, couple of things if you can bring in your practice. One is always identify the primary caretaker. Have their names and phone numbers written on the case sheet so that you know these are the primary caretakers. Always update them regularly and make a record of your updation. That's one thing. Next is on the last day, there will be people who have not been there throughout in the picture, but on the last day, they try to dominate or argue with you. So one good idea is, in case if you're going to break up bad news or you're going to talk about the deterioration of the condition or whatever you need to talk, it's always good to call for the person who has always been interacting with you. Next, never do this discussion in corridor or in an open place, because when you do it in an open place, there will be people who have nothing to do with it. They are actually attending to another patient, but they have been sharing tea and coffee with this attendant. So they'll come and stand. And if you will asking, who are you? Ma'am, I am that patient's attendant. So there you can't say, why are you here then? You are not this patient's attendant. But that's why it's always good idea to sit and talk to the patient's family member in a separate place. Second is, in case like if there are 10 people and if I've gone out to break the bad news, and I remember I was taking a similar program at Manipal University, Manipal. I had a very senior neurosurgeon, almost like a very renowned person. I don't want to name him here. He shared his experience that there was a patient operated, his condition was deteriorating. Family knew it very well. He said, when the patient died, I went out and did the breaking of bad news in the corridor. And there were other attendants of that patient whom I didn't know. They literally started fighting with me and they started beating me. Physically, they manhandled it. So it's always a good idea to do it with, like, for example, when you go out and you say, I want to share some information with you, don't do it there. I think 2 or 3 of you can come in. So that's one good way to segregate the primary caretaker from the crowd. In case if that person is still part of the party who has come for updating, you can ask him, I haven't met you. May I know your name and introduction? That would let the person know that you are acknowledging that person's presence, but you want to know who he is and what is his relationship. Then when you are interacting with everybody, do not ignore this person. You must address him, make eye contact, talk to him. But the moment he tries to say something that is not correct, you immediately move to the other person with whom you have been regularly interacting. And then you would say, please check with Mr. Ashok. I have always talked to him. He knows about the condition. Sir, I haven't met you. You have come for the first time. It's all right. I understand you may have been busy, but I think we have had regular interaction with Mr. Ashok and he knows about the patient's condition. And it is documented in the case sheet. So what you have done, you have immediately moved your attention to the person who knows you. And therefore, I always say, build wonderful rapport with the caretakers. Win their trust. You will never have violence. Most unfortunate thing that we are doing, we are giving all possible care to the patient, but we don't build enough rapport with the family of the patient, which is essential to win their trust. Address their concerns, answer their questions, whatever is bothering them, even when they come up with no money or low money or financial issues, you have to address them. We can't say that's none of my business. You need to take a call. Even if a point comes when you have to say, If you remember the 4 videos we saw last time, in the last video, that's what I said. See, if money is your concern, then you are free to take a call. I'm sorry, I don't want to burden you, but then if you ask my opinion, at this moment, the patient is recovering, and it's always useful to keep the patient under the same care. So you are giving a very balanced point of view. And I think we really need to learn how to handle mob. I think that's one training we need to give to all our healthcare professionals. So Dr. Rajesh, I hope this helps a bit.
Yeah, madam.
Dr. Indu, may I?
Very quickly, just one, please.
Yeah. So just wanted to know what did exactly, just in just one line, gist of it, what did I miss in before I joined? I'm sorry to ask.
No, it's all right.
Yeah.
It's all right. So what had happened, I had covered assertive communication style in the last session. I don't know if you got a chance to see the video.
Yes.
Yeah. But what is happening, 2 hours are not enough to cover a topic and then also discuss about pedagogies. We are spending half an hour on discussing 2 pedagogies. So from this batch onwards, rather from the next batch, I've already done the changes. But from this batch onwards, I have learned that we will have to increase the number of hours from 20 to 25. So in my next announcement, I'm already announcing 25 hours as the investment, time investment. So every session will be 2.5 hours, so that mentally we know that this is not 2 hours, this is 2.5 hours. If we end in 2 hours, 15 minutes, wonderful. But 2.5 hours are essential because I can't cut down on the content. So yes, last week's feedback, I read everybody's feedback and I saw Dr. Saifuddin's feedback where he said, where is the presentation? And honestly, I had already prepared this presentation. This was there. Even this activity on rapid fire round was there. So I said, no, I am not going to let this group go without getting this benefit. So we did a rapid fire round on, I told them about the various statements and they gave me the answer, what it looks like. Is it assertion or aggression? And they all did very well.
Okay.
And then the presentation started. I think you joined the presentation quite.
I joined the presentation, maybe from the middle or something, but then I joined.
Yeah. And then I think you can watch the video also.
Thank you so much, man. Thank you.
My pleasure. So very quickly, just to summarize this, because what I'm now going to tell you is very important. Maybe you will not get it in books. So people normally confuse being blunt, loud, and harsh as assertion. Many of you may be actually using aggression, but thinking it's assertion because I'm adamant on my point. So just to bring in clarity, assertion is not being adamant on point. Assertion is being open to talking to the person, discussing and mutually accepting what is acceptable to both the parties. That is assertion. Usually, either we don't speak, or when we speak, we become fixed to our idea and we say, no, this is what is my opinion and this is the only opinion that will work. That's not assertion. So let me quickly give you a couple of tips that will tell you whether it is assertion or not. See, we communicate 3 ways. One is your language, second is paralanguage, third is your body language. Language, throughout assertion, you will not use any abusive, aggressive, threatening language. Check your language. At any point of time, if your language goes foul, that means it's not assertion. In assertion, you will use respectful, decent, courteous language with the person with whom you are asserting. Be it your staff, be it your security staff, be it your support staff, be it your nursing staff, be it your higher-ups. Language. That's one thing. Second, now paralanguage. Paralanguage, most important thing is your tone of voice. Your tone of voice has to be firm, but non-threatening and non-pleading also. If you're pleading, sir, please do it. It's not assertion. You're pleading. Please do it. Not assertion. Sir, this is important and I request you to do it. Firm. Volume either the regular volume or can be even little slower. In case if your volume has gone up, it is not assertion, it is aggression. Third, speed of talking. If your speed of talking can be same, like we are talking now, and even little slower, that will show the impact and importance of that issue to you. Usually, when we are angry and aggressive, our speed goes up. That's not assertion. Speed, volume, tone of voice, non-threatening, non-pleading, firm. Third is body language. Most important is eye contact. When you are asserting, make eye contact with the person, even if it is with the higher ups. When you don't make eye contact, you are communicating, you are not confident. You are communicating, you are scared. But eye contact should be non-threatening, especially with your juniors, with your children, with your spouses. It should not be threatening eye contact, like big eyes and with anger. So make sure that you make eye contact. Facial expressions have to be neutral. No pleading and no unnecessary smiling and no unnecessary aggression. If the facial expressions are non-congruent, for example, if they're pleading, you are not asserting. If you are using aggression, you are using non-verbal way to communicate your aggression. I am telling you, you have to listen to me, but my facial expressions are showing anger. It is not assertion, it is aggression. When you are asserting, sit and talk. If you will sit and talk and make the other person also sit. If you are sitting and the other person is standing, you're looking like this. So you will have pain in the neck. The other person will have to look at you. So he or she will have to look like this. So it's not eye to eye contact. It's always best to sit at the eye level and talk. If the other person is not wanting to sit down, it's all right, you can stand up. Offer the person to sit. But if the person says, no, I won't sit, it's okay. If you don't want to sit, let's stand and talk, it's all right. But always sit and talk. Check your hand movements. Check your body language. Check your fist. Check your shoulders. If it is tightening, that means you are getting aggressive inside. So if you can look after these three things, language, paralanguage, and body language, having hands like this or at the back, again, that indicate you are using anger, aggression. That's an aggressive language. Or sitting like this. Sitting like this. Again, you are trying to show your authority. Rocking in the chair like this. You are showing your authority. So make eye contact, look at the person, say what you want to say, listen. Allow the person to say what they want to say. If they're interrupting, you can stop them by asserting and say, sir, when you were speaking, I heard you. I allowed you to say what you wanted to say. You'll have to give me a chance to explain my point of view. I'm open to your point of view. That means you persistence, insistence. Assertion does not mean being adamant on your point of view. You're inviting the person to talk. If you think what the person is saying is right, I think I completely agree with you. I did not realize that this is how you were getting, disturbed because of this. I'll make sure that I can help you in this. Agree. Then there can be agree to disagree. Again, politely, sir, I think you're free to hold your opinion. I somehow don't understand that point of view because this is something not acceptable to me, but I am not going to argue on that. So this is how you can. Do you think this will help? These tips will help? Thank you. So now quickly moving to the next topic, and that topic is handing over or hands off. So how many of you have issues with hands off in your hospital? Raise your hand. 4 hands raised, 5 hands raised. I completely agree. And what are the challenges you are experiencing? If you can either type in the chat box, each one of you, if you can type in the chat box, what are the common challenges you are experiencing?
Excuse me, ma'am. I just lost the signal actually. I didn't get what you said.
Okay. Okay. I was asking how many of you are having challenge with the handing over in your setup, in your hospital? Handing over between doctors,
Okay.
nurses, and other departments. Yeah.
Okay.
So are you facing problem in your setup also?
Yes, ma'am.
Yeah. So you can write what challenge are you facing. You can write in the chat box. Like Dr. Rajesh Pai has said, medication errors. Yes, because of not proper handing over, medication errors happen. Not giving clear information about the patient. Very right, Sharmish Raji. Not done seriously. Yes, that's the biggest challenge. Consultations not done in time. Billing counseling is not done effectively. Very right. What more? Anybody else would like to write their experience? What challenges you're facing? Yeah, repetition, yes. Omission and commission and repetition. Investigations are delayed, very right, because of not a proper information sharing. Nurses and doctors hardly communicate for the same message. Absolutely right. I agree with you. Procedures get complicated, wrong preparation for testing. Yes, because the patient has not been informed or the staff is not, handing over to the next person. Okay. Missed medication. Completely agree. I think common, problem everywhere. I think in most of the systems. So handing over is considered Bermuda Triangle of healthcare. Most of the information gets lost in handing over. And handing over is something which is inevitable because healthcare industry works 24/7. Yes, reports are given to the wrong person. I completely agree with you, Dr. Ratwala. So these are very common situations. We see medication error, wrong report, wrong patient, wrong, because we are not communicating effectively. We don't have proper systems in place. So I think one book that I will recommend to all of you, and that book is maybe many of you have already read it. I don't know if I talked about it earlier also. That's a book by Atul Gawande, and that's on checklist manifesto. I don't know if you have read that book. So Dr. Atul Gawande is an Indian doctor, NRI in Harvard University. He's a neurosurgeon, and he has written a couple of beautiful books in healthcare communication and healthcare systems. So Checklist Manifesto is a beautiful book that he has talked about. And he talks extensively about the errors that happen in patient care just because we are not following the protocol. We are not, doing the things in a systematic manner. So when Checklist Manifesto, that's right. Yeah. By Dr. Atul Gawande. By Dr. Atul Gawande. Okay. So when I ask nurses, like, how do you take over and hand over? Because that's the most common handover we know about. So a lot of them will say, ma'am, we go bed to bed. We go bedside and we hand over. And okay, I trust you. Then in case if the other staff comes late because you have already done your duty and you are like tired and exhausted, if the other staff does not come on time, then where do you do handing over? Then we do it at the nurses station. Okay. Suppose if the staff has come further late, for example, you have waited for good 10 minutes and it's like you were supposed to be off by 2 and it's already 2:15 and the other person has not come. And then we do it in the changing room. When we are changing, we talk about the patient, what needs to be done for each patient. If the person has further come late, then what do you do? Then we do it at the gate and we tell everything is all right. I've written everything in the nurse's report. And in case if you have any difficulty, you can call me and check with me. And when I ask doctors, how do you hand over? Is there any proper handing over between doctors? Yes. So I was taking a session with a group of ICU doctors. I said, how do you hand over? After all, you are
medical officers do, ma'am.
But not every hospital has that system where medical officers hand over. So I asked these doctors from the ICU, I said, how do you hand over? One of them in a very humorous way, he said, ma'am, our handover is, ये सब ठीक है, इन दो को देख लेना.
That's right. That's how it is.
So imagine what we are doing. And that's where the continuity of care breaks down. That's where the patient safety gets compromised. That's where wrong medication, wrong procedures happen when we don't hand over. And we are just talking about the handover in the same department. That's incomplete definition of handover. When the patient is going from one department to, for example, for radiology or to lab or to physio or to OT, there is supposed to be another handover because the patient is transitioning from your care area to another care area. But there's no proper handover. I remember my brother was admitted in one of the hospitals. He's diabetic. He is diabetic. He was admitted by a doctor well known to me and my husband. So he went to the admission counter, got his admission done. He was taken to the ward. He was admitted in the room. And then every time my brother and Bhavi checked with the doctor and the nurse on duty that what next, he said, abhi doctor aayenge, abhi doctor aayenge, abhi aayenge. It took good 3-4 hours for the doctor to come. And my brother is diabetic. What about his medicines? What about his diet? Then when they said that should I take medicine? What should I take? They arranged diet. He had dentures and he had not brought his dentures and they gave him regular diet which he could not eat. Now imagine a diabetic patient taking medicines but not getting proper food to eat. Where will his sugar go? And these are everyday errors. Everyday errors. I've just quoted a small thing. In another hospital, in a government hospital I'm talking about, a lady delivered a baby. She felt that she's bleeding little more than normal. She informed her mother-in-law to go and inform the staff on duty, the doctors on duty. There was a changing happening, the shift change was happening. So the doctor who was handing over, he said, there's this patient, she's probably complaining of little more bleeding, go and see it after you have taken over. He handed over and went away. The next resident forgot because it was a verbal handover. Forgot. By the time they realized the patient had gone into PPH and we lost that patient. That lady died. So handing over is probably the biggest challenge for all of us, just because it's not implemented and not taken seriously. And some people, some systems believe we are beyond it and we are not supposed to handing over in a systematic manner. So let me quickly share the presentation with you and discuss it further. So I think patient handoff is the biggest challenge and we really need to talk about it. And when you are taking this as a session in your training programs, this should be included in your curriculum or in the topics that you're going to talk with your audience, because it's a very important topic. And when you will discuss, it really brings the seriousness of the concern to the knowledge of the audience. So just take this case. I have underlined one line in this. So after you have read this, just read it. So what is one message that you think is going to stay with the person who is taking over?
Nothing much to do.
Yes, so true. Nothing much to do. What about this one? What do you think is going to stay with the person who is taking over?
That there are chances she has to be shifted to ICU.
There are chances that this patient may need to be.
Condition is very critical.
Condition is very critical. The sickest patient is Rani. What about other patients? So a typical handoff is more like, where the sender is saying something like we talk to our pet. And we say, okay, Ginger, I've had it. You stay out of garbage. Understand, Ginger, stay out of the garbage or else. But the person who is receiving is just listening to some words that are familiar, easy to remember, and easy to apply. The receiver may not retain everything. So cognitive processes like selective listening, selective attention, selective forgetting interfere majorly with the verbal handover. And usually we write little bit in the report book, but most of the handing over happens verbally. So selective listening, selective attention, selective forgetting are the common cognitive processes that interfere with actual handover. So do you know, are you familiar with these terms? What do you want me to explain? Anybody? Are you familiar with these terms?
Yes, ma'am.
Selective
Selective
I
listening.
think we are familiar enough, but your inputs will enrich us more.
Sure. So selective listening is you would listen what you are more focused on. For example, if the moment you have heard that this patient is recovering and is going back, so everything else will be kind of faded off, would get deleted from your active memory. See, our RAM is very, very small. And we have a tendency to forget what is non-essential. So what mind chooses as important will select and will listen. Rest will be slowly faded out from the active memory. Selective attention also, what you want to attend to. Rest, everything else is completely forgotten. I wish we had time. I could have shared one video with you to help you understand how selective attention, completely fogs your mind to the non-essential things that the mind think are not essential. Then selective forgetting also. A lot of time you may have seen, you explain something to the patient or the family, and when it comes to talking about it later, they'll say, no, you haven't told this. I was never told about it. I did not know about it. And then you say, no, this was explained to you. I told you everything very clearly. But they'll say, no, it was not told to me, because mind uses selective forgetting as one of the ways to deal with the reality. We tend to ignore some of the facts or forget some of the facts because they are not comfortable or we don't want to attend to them. So these are the cognitive processes that come in the way to effective handover. Okay. So according to JCI, I think this is one of the critical safety and quality problem, and you have all agreed that even in your healthcare systems you are facing this same problem. So in 3,000 sentinel events from 1995 to 2004, they found out that 65% of them had problem, and that was because of the poor communication. And over and above that, it increased to 70%, and 50% of them was during the handoff. So you can imagine how communication failure happens during the handoff, because the person who is going is tired, exhausted, and is in hurry. And the person who has come assumes I can manage. And as a result, the proper handing over does not take place. So why do you think effective handoff still remains a primary challenge in the healthcare? What do you say? Why is it still a problem? In spite of the fact that we have so many protocols available, I see a lot of hospitals have a very systematic, format, template for handing over. But why does it still remain a challenge?
Madam, it is issue of ownership of the patient. It is about the ownership of the patient. No?
Yes.
In
open
ICU, in that is the open ICU, there is the intensivist and there is the primary care physician. Who is supposed to take care of the patient? It is the intensivist. But all the the financial payment goes to the primary care physician. Here he feels, why should I do all this trouble? After all, he is taking all the. I'm just being very frank, because I'm an administrator. They feel that why should I am taking all the burden and he takes all the
So that is
money.
so that, Dr. Pai. So what you're talking about is probably the care part we are talking about. But if I ask you very specifically, why are we not able to implement handing over in a very true spirit in the right way? It's mostly on the paper. So Dr. Khalid has very rightly said consistency of care is I completely agree with you. I think that's one challenge we are facing because of improper listening. So why are we not able to implement? That's my question to all of you. Why are we sorry?
Yeah, one is the patient-nurse ratio. Most of the time, they won't be adequate nurses to do that. So they will be overloaded with this thing. So that is one thing.
They're already multitasking. So over and above that, we expect them to be okay. Wonderful, that I agree. Anything else? Anybody else want to write or say?
On time constraints, like if they are having the 8 hours duty, they have to give the medication administration and they have to do a lot of procedures. So they are not. The second point is that employee turnover, like attrition. The new people are coming, you have to train them. When you train them, after 1 year, they tend to move from a hospital. So
if I ask one question to all of you, in how many hospitals have you kept half an hour to 1 hour as an overlapping time between the two shifts? Dr. Anuradha, in your hospital, do you have this?
Yeah, ma'am, I was working with, I was with a pediatric surgeon for about 4 years while I was assisting him. So we had 1 hour of overlapping because it was a pediatric surgery hospital. So a lot of work was there with each child. So there it was implemented.
And I'm sure you would have found it very, very useful. Dr. Anuradha, I think there's a network issue. In any other hospital, do you have this format where you have overlapping time?
Yeah, so we had an overlapping of around 1 hour, but that probably was generated out of your training need. So that both the shift nurses could train during that time. So it was not probably for handing over purpose, but for this. And we found it useful for the training purpose.
But I want to ask you, if you have around say 40 to 50 patients in one floor, what is the average? 30, if not 40, 50 on one floor?
Yes.
30. Even if I have 30 patients on one floor and I need to hand over all of them, and I need at least 1 to 2 minutes to talk about each patient. If I have to go to every room and tell the patient, okay, मेरी छुट्टी हो रही है, अब ये मैडम आई हैं, ये आपको अटेंड करेंगी, सिस्टर इस पेशेंट का जो है बेरियम मील के लिए इनको रेडी करना है, and this patient is diabetic, so we have to make sure that though he's empty stomach, but he's given IV fluid so that his blood sugar does not go down, and this preparation need to be done. So 1 से 2 मिनट लग सकते हैं, 2 minutes per patient. लग सकते हैं? Am I saying right?
Ma'am, I think 10 minutes means for nursing.
मैं तो बहुत कम लेके चल रही हूँ. 2 minutes. I'm just talking about 2 minutes. ठीक है. 30 patients, 2 minutes, that means at least 60 minutes I require. Unless I have kept that overlapping time, tell me the person who has to go. If the person knows 2 o'clock I have to go, I get my bus or my car or vehicle to reach home. And by 3 o'clock, I need to reach home and my children will be coming back from school. So I need to prepare their food or whatever my household responsibilities are. Will this person stay for 1 hour? This person who has come now, if I ask this person that you have to come 1 hour before your duty, will that person come? Unless you have a system where you have a overlapping time between people who need to hand over and take over, you will never be able to implement handing over in a systematic manner. I think one thing we clearly need to remember, unless there is a system, there will not be taking over and handing over. In aviation industry, till the ground staff or the inspection staff comes and does the complete checklist inspection and signs the document and hands over that document to the pilot cannot take off. But we don't have that system here. So naturally, there is no accountability. If it needs to be done on paper, we do it. We have been assessor, we have been to so many hospitals and we have seen how they just put tick mark for everything. Because nobody's going to check when was it tick mark. Was it really done or it was just tick mark? So the biggest constraint in handing over, I think, is that we do not have time. We haven't actually kept defined time for handing over. Unless you'll have this in place, you will always have challenge. The other issues and dilemmas that are there because of improper, leading to improper health handing over is the methods of handing over are ineffective. In some places, it is very unstructured. In some places, it is one way. It's only verbal. In some places, we have it structured, but it is too complex. It requires time, commitment, and process change if we want to implement it in a real sense. Also, there is extreme variability. A patient in an orthopedic ward will have a different kind of need than the patient in the ICU or in a pediatric surgery or in a neurosurgery department. So there's extreme variability when it comes to handoffs in different areas. So that means we have to come up with different handoff templates to make sure that we cover the required need of that particular handoff. There's also lack of focus research on healthcare handoff. We don't have much research, at least in Indian context, where we have actually studied the handoff in a real sense. So anyone has done any study in their hospital? Anybody? Dr. Pinky, Captain Sandhya, Dr. Pai, anybody has done any focused research on healthcare handoffs in your systems?
Not exactly, madam.
Not exactly. So that means we do not have any substantial data to tell what is the right way of doing it. So this is one report I'm sharing with you. In this, 12 simulated patients were handed over and 5 consecutive handover cycles were performed, but 3 different styles were used. In one style, it was just verbal handover. In the second one, it was mainly written, what we are using right now in our most of the hospital. And the third one was that there's a standardized form and also verbally you hand over. So they compared the results of these 3 styles. In the verbal handover, almost all the data was lost because we forget 80% of what we discussed within 24 hours. In notes, when we are creating notes, it resulted in loss of 31% of the data. Still, it was better than the verbal one. That's why we are using it more often in our setup. But the best one was where you actually follow a standardized form, but also you have a verbal handover going bed to bed, which led to minimum loss. So evidence-based research shows very clearly that ineffective handover leads to wrong treatment, delay in treatment, severe adverse events, patient complaints, medication error, procedures error, lot of things. And then it also increases the healthcare cost and also the length of the stay. So we have to create system, create culture, and bring in individual changes if we really want to, implement handoff in a real sense. So handoff is more like a two-way street where the sender is supposed to be telling about what exactly happened in that person's presence, because a person has attended the patient for 8 hours. So the patient, for example, if I'm talking about the nurse's handover, so you have attended the patient for 8 hours, so you know what exactly happened with this patient in your period. There, you are literally like painting a picture that the other person has not seen. So you are supposed to give all relevant information, need to give specific directions and rationales what needs to be done in the next 8 hours or maybe 12 hours or 24 hours. And then also confirm whether the person has really understood. On the other side, receiver is responsible to listen attentively, ask questions, and use systems to remember important information, like writing down or making notes to make sure that you are understanding. And also read back so that you are able to communicate that, yes, I have understood. So there's a saying that says, handover is never given. Handover is always taken. If you are receiving a patient, you are responsible for the care and safety of the patient during your tenure or during your time when you are going to attend the patient. So as a receiver, it should not be a passive role that you play of just listening and saying, okay, I've understood, go. It's always advisable to listen attentively, ask questions if you are not clear. Also note down what you think you need to note down that you need to execute, and then read back to confirm whether you have really understood. That's how you will be actually able to take a real handoff. So we really need to learn from these, industries, the proper way of handing over. For example, if you will look into the handing over tools and techniques in nuclear industry, NASA, mission control, aviation, dispatch services, they have excellent way of handing over. Especially if we talk of very simple thing like dispatch services. Very rarely you will receive a wrong parcel or it get delivered to a wrong person or in a wrong place. Mostly these are very precise, very accurate, because their handing over is very accurate. Somehow in healthcare, we do not take handing over very seriously because we are not used to it. It was never considered as part of the, protocol or treatment. And some of us feel we are above it, and why the hell should we take over or hand over? We can manage on our own, which is not true. Handing over is transfer of duties, rights, and obligation. And if you remember the purpose is continuity of patient care and safety of patient. If we remember these two purposes, I think we will never underestimate the power of the right handover. So different handover, I think we all have seen. Most common, I think, is between the nurses. Then there can be a handover when there is a change in the level of care. For example, the patient is moving from OT to ICU or from ICU to ward. Even between doctors, when there's a shift change, it's supposed to be a proper formal handover. Physicians, when they are transferring the patient from their care area to another one. For example, a patient has come with some multiple comorbidities. You have attended the patient, or the patient needs to go to orthopedics or to neurology or to any other department. So there will be a transfer of care, but then a proper handing over has to happen where you write your notes and you write the reason why you're handing over and what you are handing over. It could be cross coverage. It could be, in the same unit. Then when the patient is transferred in and out of the hospital, again, there has to be a proper handover. If the patient is coming from another hospital, the patient has to come with a summary of what has been done, or what is the case like, and what is expected, or what you are expected to do. There are other handoff also, which we probably do not take as handoff. For example, when you are sending a referral call, so if you're calling somebody, so it's again a handoff. Then when you are talking about the critical reports, for example, from lab to the respective consultant or the primary physician, if you are sending a critical report message, it's also a handoff. When the patient is transferred to home or to a skilled nursing facility, even that's called a handoff. Other transition in care, for example, if you're sending the patient to radiology or physical therapy, or from emergency, you're moving to the ICU, OT, or labor room. Again, this is a handoff. And again, same protocol has to be followed in the same manner. So this is one very simple handoff tool people are using across the world, and they find it very useful, and that's called rule of 5P. So whenever you are handing over, if you can talk about the patient, what is the plan, what is the purpose, the problem that the person can expect, and the precaution that you want the person to keep in mind, that's a wonderful way of simplest, I'm talking about simplest way that people are using. But this does not meet the requirement of complex cares areas. So there we require a more, detailed handoff. So for example, this is patient Ram, 54 years, to become empty stomach for barium meal test. He's diabetic, so you need to check his blood sugar every hourly to regulate his blood sugar accordingly. Okay, make an attempt of this handoff now. Can somebody try this? Write in the chat box. What will you write if you were supposed to hand over? Would somebody like to try? Just one, maybe one of you, okay? Anybody who is willing to try? Patient Kishore, 14 years, plan to wean off oxygen. Okay. Okay, purpose is to discharge. Okay. Now you see, again, we are majorly talking about what is going on and then what is the plan. This is very true. This is
plan.
How we normally... Yeah. Sorry, go ahead, please.
No, but plan is to wean off, you said, no, Dr. Indu?
Yeah, plan is to wean off, yes.
Purpose is to discharge, okay.
Yeah. Dr. Anuradha, would you like to try? If you have
Yes, ma'am, I can try. I have not written it.
It's okay. That's why I'm not removing the slide. I'm not removing the slide.
So patient is okay. I cannot open my chat box. That was the problem. I can try it. So I can say patient is Kishore, 14 years. Plan is to wean off from oxygen. Purpose is to discharge tomorrow. Problem is he's asthmatic. Precautions is to take care of his, to keep a watch on his oxygen levels.
Correct. So you have actually tried using 5 Ps. Am I right? It's still making sense. Instead, if you remember the first slide that I had shown you, where it said that there's nothing much to be done. This patient is going to be discharged tomorrow. Just try to wean him off. So can you see the shift in the content? This is looking more organized. What you are saying is looking more organized. Besides this, I think we need to talk about a couple of other things. For example, his condition of asthma and how it got triggered. Also about nutrition. Also the amount of oxygen we are giving right now. Sorry, I'm so sorry. Yeah. And also the infection the child had. So that means we were still focusing on the plan and purpose, but there were many other things that we need to talk about. Okay, take another case. So this is something that I will recommend to you to do in your hospital, in your if you are doing a training on handoff. This I normally do when I do a training on handoff. So what I do, I divide the whole group into smaller groups where 3 or 4 members will be in each group. Ask them to write minimum things that you think should be part and parcel of what ideal handoff. I will make them into subgroups in a on-site program. You can make them sit around a table, and 3-4 of them will be doing a group activity, and you'll make 3-4 groups. So that means 4 groups are working on the same task. You'll make them create a list. Then you will ask them to discuss in a larger group their respective list, and then come up with a final list. Say them, we want 10 things that you think are must for any handoff. So that's how you are making them realize the importance of different things. For example, patient's name, age, or his present diagnosis or treatment. So when you make them do this as an activity, they get to realize how important are these finer details for the patient. So I made them do, normally this activity takes around an hour or so. So I'm not making you do this activity. If we had time, we could have done this. So when I made them do, this is what they finally, decided, that we should have at least the identification of patient, diagnosis and comorbidities, present treatment and response of patient to the treatment, chief complaints and intervention done in the past 8 hours or 12 hours, then vitals including the sensorium and general health, any adverse event happened and intervention done or expected in the last 8 to 10 hours on the next 10-12 hours. Also talk about plan of care, plan of investigation, procedure, surgery, any pending plan, any special instructions to be part of the handoff. Then any investigation done or pending and the findings. In case investigation reports have come, so you need to talk about those reports. In case you have sent the sample, then what you are expecting and when you are expecting and how they are supposed to be collecting it. Any critical reports received or expected, that also needs to be part of the handoff. Then the present medication that you are giving. Besides that, intake and output, including diet, IV, in case if it is rice tube, then rice tube, type of diet or nil orally. In case on oxygen, then talk about oxygen, what is the quantity of oxygen you are giving. About output, we need to talk about the urine, stool, and the drainage. So that means this has to be the minimum part of the ideal hunt. And this was chosen by number of groups. When I did this activity with number of groups, this is finally came up. But then you can use this as an activity when you do it with your audience or with your staff. So this engages them in preparing the list, and automatically they understand the importance of these aspects when you are handing over the patient. So handing over is passing the torch and not the buck. I think this is one thing that the staff should understand, that we are handing over the patient to make sure that the patient gets a a continuous care without any mishap or any confusion. So what are the barriers to effective communication? What do you think are the common barriers to effective communication when it comes to handing over? Even when people hand over, what are the common barriers? Suppose we have seen people handing over. Time is one constraint, like you said, workload is another. Patient or nurse-patient ratio, some in most of the hospitals is not up to the mark. That's very common. Environment in what sense, Reena? Can you explain? You are right, but I want to understand it. What we exactly mean by it.
Ma'am, suppose handover is going on and there is some construction work going on, or maybe somebody is continuously ringing the call bell, or somebody's room, the TV is in a very loud mode. So that's like, or somebody is like chatting on their own, these kind of.
True, that is possible. Language can
also,
be
also, ma'am, in case when handover is going on, new patient admissions or some emergency patient comes, then it becomes difficult for sisters.
That can be situational barriers. What you're talking about is what Reena said, and what you're saying is situational barrier. But the usual barrier that actually interfere with the handoff as a procedure is one is human fallibility. If you will see some people hand over in a very systematic manner, some people will not remember, some people will not do it in a right manner. Then, as I said earlier also, there is complex system. Healthcare is not a uniform one level care. Different system, different departments require complex systems, so naturally the same protocol cannot fit in the same place. Then there's a limitation of learning and training. Some of us have learned that proper handing over has to be done. Some of us have not learned what is the right way of doing it. So we do not know what is the right protocol of doing it. Then can be continuity gaps even by the persons or by the system also. There can be negative impact of fatigue. When people are tired, they are less likely to give detailed information about each patient. They may try to cut short, or they may say that everything is written. Have a look, and in case if you have any problem, you can talk to me. Time constraints we have talked about. Usually when we don't have overlapping time, nobody would like to give extra time to stay and hand over. Then the volume of information is sometimes so huge that it is practically not possible to verbally tell everything and also retain everything. Confidentiality can be a challenge when it comes to handing over sometimes some information, whether you should really be sharing with the other person or not, that you have to really consider. Then there is a difference in styles of communication. Some people like to speak more, some people like to speak less, some people like to give more information. Also, there can be a difference in the style people communicate. There can be gender differences also, especially communicating with the opposite gender can be a challenge for some, so they may not hand over in a proper manner. There can be cultural concerns also. Concerns where you don't have that culture of communicating with another sex person or with another person, so that can come as a barrier. Then hierarchy of decision making. So when you think the decision making is in somebody else's hands, so you feel less empowered, so you're less likely to talk about the treatment or the detailed information about the patient. And then level of respect between physicians and nurses. A lot of time nurses feel that, oh, we are just here to execute, the decision has to be taken by the doctor or the consultant. So they feel, okay, it's not me who is going to talk about the treatment or the care plan. It is the doctor who is supposed to be talking about it. And then level of empowerment. I think these three are interrelated. All three are interrelated. So we have seen a lot of communication challenges between doctors and nurses. One is definitely that their style of communication can be different. Some people are very authoritative, very upfront. Some people are passive. Some people are hesitant to talk. Then hierarchy, of course, we all know there can be challenge with the hierarchy, and people may not, feel comfortable talking to people in the higher ups, and especially when it comes to talking about the patient's care plan or complication or situation. Past experience where they have been kind of snubbed or intimidated, people will not feel comfortable talking about a patient. Level of empowerment, I think we have talked about. Tone of voice, if the person is using authoritative, rude tone of voice, the other person will become passive and will shy away from discussing it further. Okay, quickly talking about the tools of handoff. How many of you have heard of these? SBAR, ISBAR, sign out, I pass the baton. Have you heard of these? Have you heard of these as tools of handoff?
SBAR we have heard, huh?
SBAR we have heard.
SBAR.
SBAR, I think these are very common one being used. So I'll quickly talk about ISBAR because that's really used very often by healthcare organizations. But then there are many more. For example, if I talk about I pass the baton. So in this, I is introduction, that is introduce yourself. There's an acronym actually. I pass the baton is an acronym. P is tell about the patient, the name, age, sex, and where the patient is, which ward, which room. Then what is your assessment? What do you think is the problem right now? What do you want to talk about? Then situation, what is the current status and the circumstances? It could be uncertainty or recent changes. It could be drug reaction. It could be some change in the patient's condition. The second S is for safety concerns, in case, especially if it is about the critical lab values or reports. Suddenly you have received some information about the patient's lab reports and you want to communicate about the patient. So you will identify yourself, you will tell which patient you're talking about, then what is the patient's, whatever the tests were done, and then what report you have received. That would be part of I pass the pattern. And pattern would be B is background. So you will talk about the comorbidities, previous episodes, current meds, family, to give the picture, especially if the person is not there in front of you and you're making a phone call or you're informing the patient who's at a different location. So you will have to really give more details for the person to recollect about whom we are talking. A is what action to be taken or you think have been taken that you need to, you want to share with the person. Timing, what is the level of urgency? If you want that person to come immediately, if you want the person to come and see the patient. So explicitly you will say the level of urgency and prioritization of action. And then O stands for ownership, who is responsible. Sir, so you are kind of, sir, I think it's important that you need to come and see. So you are trying to give the ownership to the person. So it could be the patient, family, doctor. You need to mention that very clearly. And then N is next what happens, anticipated changes and contingency. So this is I pass the baton. What we see very often being used, okay, this is the communication checklist which you should follow when you are communicating in using any handoff tool. So first of all, when you're talking about any patient, get the person's attention, make eye contact, face the person, especially if the person is right in front of you. Use the person's name to whom you are talking, express your concern, use these techniques we are going to talk about ISPAR in a while, and then reassert as necessary, decision reach. For example, you found that the person's blood sugar is very, very low, say something like 40, 45. So you are kind of informing the resident on duty that this is an urgent, an urgent intervention is required. And you use this tool. So you explain in a manner and then using this technique. And then in case if it needs to be escalated, escalate if necessary. Now, quickly have a look at the ISBAR as a tool for, especially for the referral call. So ISBAR is I stands for introduction, where you, and S stand for situation, B is background, A is assessment, and recommendation. So introduction is about state your name, who you are, especially if you're making a call. How will the other person know who is the person who is calling me? So you need to tell your name, you're a doctor or a nurse or whoever on duty, from which unit you're talking, from which ward you're talking, then about which patient you are calling. Patient's name, bed number, room number, ward, that needs to be part of the introduction. Next is S, that is situation. So what is the present problem for what you are calling? It could be about the blood transfusion that you have started, or a new medication that you have given, or having some patient, having some drug reaction, or it could be a preoperative observation. It could be change in the vitals. It could be change in the mental status, or patients, patient stable, unstable. So that could be a situation for what you are sending the referral call, or you are calling the resident or the consultant. So besides this, you need to give background. So when we talk about background, the idea is the other person should get to know about which patient are we talking and what are the what is the relevant information. So in background, maybe you'll have to talk about the pertinent medical history, any allergies, sensory impairment, family location, religion, culture, interpreter required, valuable. So this could be not all of it, but whatever you think is relevant to be shared with the person with whom you are calling, you will have to tell about this. I will do a couple of exercises you will get to know. Assessment, that is ISBAR. A is assessment. So here you will talk about the vitals that you have checked. What is the present condition? What is sensorium? What is the severity of pain? In case the patient is bleeding excessively, you talk about the bleeding condition. In case you have come across any critical lab report, then you talk about that critical lab report. In case the patient has some rashes, some blisters, so you talk about those skin changes. If you see any risk factor and issues that you are concerned about, that all will be part of your assessment about the patient. In recommendation, what do you recommend or what do you request? So for example, it could be that I think the patient requires pain medicines, or the patient requires isolation, or the family needs to be communicated, whatever is your understanding that will help reduce the severity or manage the situation, is your recommendation or request. Or if you want him to immediately come and see, so that also is part of the recommendation. So that's about ISPA. So this is a situation, for example. All of you can have a look at the exercise. And if I ask you to convert it into ISBAR, first write it in your notebook, and then maybe one of you can share what will go in I, what will go in S, and what will go in B, A, and R. You can write in your notebook first. If anyone has finished writing and would like to present, can unmute your device and
So, ma'am, may I?
Sure.
Yeah, so suppose the patient has come to emergency and I'm a staff nurse and I want to inform the doctor. So I'll just call and I'll say, sir, myself Pooja, I'm staff nurse, as a staff nurse calling from emergency department. Sir, is this Dr. Atul? Sir, there is a patient, Mr. Rajesh, who is 50-year-old male. He has met with the road traffic accident, and he has multiple minor injuries. He's all over the body, but no visible sign of grievous injury. And he's complaining for diplopia. His vitals are stable, but he seems to be slightly confused. Sir, I have checked his Glasgow coma, and it's like E3, V5, M5. So, sir, will you please come and see the patient?
Okay, good attempt, I would say. Very good attempt. So if I convert it into ISBAR, it will look like this. Hi, I'm Dr. So-and-so, or hi, I'm nurse so-and-so, doctor calling from emergency ward so-and-so. I would like to come, situation is, I would like you to come and see Mr. Rajesh, 50 years old man on bed number 3 is complaining of diplopia in the right eye. Background will be that it's a road traffic accident case brought an hour ago by the police. He has multiple minor injuries, or because when the moment we say RTA, the person does not know what is the severity of the condition. So we need to tell that he has multiple minor injuries all over the body with no apparent grievous injury. So you are kind of informing that it's not like in a very critical condition. Then it is as your assessment, you said his vitals are stable, but he seems to be slightly confused. So that's your assessment of the patient. And the recommendation you are saying, or request you are saying is, will you be able to see him at the earliest? Also, what would you like me to do in the meantime? So little here, little there, it's all right. But then introducing yourself, talking about the patient about whom you are talking, telling what is the case, what is the situation? What is the present complaint or present issue that you want to be addressed? If we systematically do it, I think the other person gets to understand the situation in a more clearer manner. So that's the idea when you use this as a tool to communicate about a patient. Now, the second one, again, it's another patient who developed skin rashes after receiving first dose of antibiotic. So you want to now call the doctor to come and see what is the, what needs to be done. So he's type A diabetic, and he has come today in the morning for, wound infection at the appendectomy site. He's anxious and is looking all red with rashes over arms and chest. Vitals are stable. Temperature is normal. He has finished his dinner and his wife with him is very agitated. So this is an additional point that you want to bring to the knowledge of the doctor, that the family is agitated. So that means we need to handle it as early as possible because the family is kind of, aggressive or anxious about the condition. So similarly here, I'm doctor or nurse so-and-so on ward number so-and-so. I would like you to come and see this patient who had a significant skin reaction to an IV antibiotic. So you have very clearly mentioned that this is because the skin rashes are because of the antibiotic that was given to the patient. So now you're giving as a background that he was admitted in the morning for the treatment of appendectomy wound infection. He is type 1 diabetic because they are all related. And this, we were giving him his first dose of gentamicin, metronidazole, ampicillin. As your assessment, you are saying this, his vitals are normal, but he's anxious and appears flushed with anything. And then and you can also mention about the family being agitated. And as a request or recommendation, you're asking, will you be able to come and see him urgently? Or what would you like me to do in the meantime? So when you communicate in this structured manner, you are likely to get better results. So benefit of proper handover, continuity of care, patient safety, decreased errors in patient care. Some of you said repetition. So there will be no repetition if you are properly handing over. Of course, patient satisfaction and professional satisfaction that you are going to enjoy. So if you are planning to, and this is the benefit of having a standardized communication. If you have a format or template that you can use in your setup, the template helps in creating a mechanism where the focus is on the patient and not on individual. So I will not hand over as per my style. I will go by the protocol. Therefore, I will give specific information in the right manner. This standardized format will also allow all parties to have common expectation. What is going to be communicated, how the communication is structured, and what are the required elements. What is expected to be told. So it's always a good idea to have a standardized communication template uniformly applied in your hospital. Of course, with variations as per the requirement of the department. But some basic, communication template have to be developed. So when you are going to implement, suppose if you are seriously thinking of implementing it in your setup, I think the first thing that we need to do is assess all points where handoff occurs. So have a visit to various departments and see where all handoff occurs. Then concurrently monitor processes at all points. How are they doing it right now? If you will observe, if you will do the process mapping, you will get to see what are the communication gaps. So if you are able to identify those communication gaps, so you will make sure that when you are preparing a template, those communication gaps are addressed simultaneously. Once you are ready with the protocol, identify champions, identify physicians, identify nurses who will be willing to implement it. Because if you try implementing it all across, everybody may not agree. So best will be handpick couple of places, department or people who would start implementing it. So you will see people trying to, implement, and then you will be also able to see what is lacking in your implementation. So select a consistent approach, develop a policy and procedure after you have developed your final template. Educate staff what you are going to do and why this needs to be implemented. Implement the policy of handing over. Monitor and report the findings, whatever you find, and keep updating the procedure and the template, because that's one thing you will need to do at least for initial some time, so that if you're missing on something important in your handoff, that needs to be included, and we can keep updating the procedure and the template. So take home point here would be that most of the errors in patient care are communication failure and because of the ineffective handing over. And handing over is an important communication tool for continuity of care and patient safety, and it cannot be taken lightly. It should be actually done in a very, very systematic manner. So while giving handoff, we need to be very specific, concise, and deliver the information in a standardized format. So therefore, repeatedly we are saying that have a standardized format so that you would know what to tell. And while receiving a handoff, very important, listen attentively, ask questions, summarize what you have been told to confirm that you have understood it rightly, and then read back so that you can check if there's anything that you have missed. Okay. Any questions about what we have discussed about handover? So do you think this will help you in bringing change in your workplace, implementing it in little more simpler and acceptable manner? I think biggest thing that we have to work on is creating motivation to accept this as an important integral part of patient care. If you can bring in that attitude change, implementing and improvising and making it better should not be difficult. That has to be done very, very seriously and systematically. And one of the ways is that you need to sensitize your healthcare providers about the importance of effective handover that you need to.
Very important part of the healthcare, the current scenario, when there are multiple departments and multiple level of staff, paramedical staff, like a respiratory therapist and nurses, doctors, junior doctors, all are there, and then this communication between them, interaction between them, very crucial. Otherwise, lot of errors. What is pointed out in JCI is only tip of the iceberg. In India, nobody records anything, so it'll be far worse in India. Sentinel events will be happening, and many of the things are brushed under the carpet.
I completely agree with you. I completely agree, especially when there are multiple, consultants involved in the patient's care. So that means there has to be a primary nurse and a primary physician for the patient to make sure that that person keeps track of what is happening in the patient's care and updates the records on regular basis. So you will have to actually find out different ways that will work to ensure that the continuity of care and the patient safety is not compromised. So you'll have to be really innovative in finding ways what will work in your setup. I completely agree with you. But yes, we need to create a system where we hand over the patient in the right manner and also record whatever we are doing in a manner that everybody gets informed about the updated care.
Some areas they do it like tumor board. There's a
My
tumor
class
board
is going on. I'll get back to you.
Oncology patient when they decide the course of treatment. It's surgical oncologist, medical oncologist, radiation oncologist, radiologist, pathologist. They all sit together and then decide the therapy. So similar things should come in more areas like the ICU you mentioned. It is, and you, madam, I want to tell you that the shift plan change more of 1 hour. That happens very much in the OTs. I think the nursing, Puja and others may be able to know that in the OT it happens very smoothly. Because OT is considered to be very critical, but we are not considered ICU that much critical, and ED also. So that so the handover is smooth because one person comes in during surgery and then he goes out and then she has to know everything, the gauze count, how much blood is lost, what is to be given, what stage of surgery, everything is explained and it happens very smoothly. So some areas it is happening, but some areas we have a problem.
And most of the errors are where we are not taking it very seriously and we are doing more of a paperwork than the real.
Yes. Somebody says checklist has become a tick list. No,
tick list. I think you're very good. So good. So true. I completely agree with you. So I think it's, what is the time? It's 9:30 there?
9:30.
Can we have the two presentations by Dr. Pai and Pooja? I want the group to now take a call. I know it's quite late. What I would say, can we join half an hour earlier next time?
Yeah.
Because it's very late for all of you. You all must be wanting to have your dinner. Even I haven't had my breakfast, so don't worry. I'm with you.
Yeah. So,
but this was an important topic.
Can we not have it on a Sunday? Because every day I reach by 6:45 from my hospital. So joining at 6:30 would be problem. I'll be missing 15 minutes and I have to depend on the video recording. So, I mean, okay, there are just 2 sessions left, but we can manage because any question, you're always there to help. So that can be done. It depends on everyone.
I want everybody to give their opinion. Whatever is suitable to you, I am available. I am okay with whatever everybody says.
Sunday
maybe for the next session, be ready for another half an hour. We start at 7 and go up to 9:30. And instead of 2, we will have 4 presentations. Is that okay? 2 we will have in the beginning, then we'll have my session, and then we'll have 2 sessions. And be ready to spend 30 minutes extra. But for my future programs, I'm going to announce, I've already kind of announced that it is going to be a 25 hours program. Because 20 hours are not enough for us.
Madam, I really want to compliment your presentations. So many new ideas you have got. And it was really wonderful.
Thank you so much.
We didn't realize it was 9:30. You kept it interesting.
Thank you so much. I think that's the purpose, that all of you should be able to use it in your real life situation. It should not just go as a theory and something that cannot be applied.
Very true.
I think that's the idea. And this activity of, making people develop their handoff tool. I have done it and it goes really very well with the audience, because when they do it themselves, they realize the importance of it. So whenever you can do it with your staff, you'll find it having, people understanding its importance. You can try this also. So very quickly, let me share the feedback form and then we close it here. Is that okay? Just give me a second to share the feedback form. Yeah, I've shared the feedback form. So if you could quickly give your, and the next 2 sessions will be for 2.5 hours. Let's be prepared for it. Also, you need to give me the final word. When do you want the next session? Same day, Friday, or whatever day you decide. And who are going to present in the next session besides Pooja and Dr. Pai? Dr. Anuradha, you are still left. And Dr. Anup, will you do? Fine. Dr. Anuradha, you and Dr. Anup, you will do?
Yeah, I'll do it next week.
Yeah. So if you need any help from me, please get in touch with me.
Yeah.
Although I know we have already spoken once, so you are already ready with your thing. Dr. Anuradha, once you have made your preparation about your topic, so you can send me a message. We'll get in touch with each other. I'll give you a WhatsApp call and we can discuss.
Yes, ma'am. I'll get in touch with you, ma'am, to understand how to make it also, because I have missed beach mein 2 sessions. So I'll get in touch with you.
Sure. Sure.
And next session, class we are having in the next week, ma'am?
Yeah. I was keeping it on Friday. I think this is what we had discussed, but in case if you want any change in the day, then maybe you can, I think all of you can give your option in the group, and whatever is the majority we will keep. But time will be 7 to 9:30. So have something before you sit for the class. In between, you can take tea, coffee, juice, whatever you want to take, so that we can spend 2.5 hours together. So I think all of you have done, or anybody is left. Raise your hand, those are still doing. So I have received 8 responses. Somebody is left still. I would request one of you to put this in the group. Pooja, can you do this? Feedback form in the group, if you can put it. So that those who have by chance left. Dr. Leah messaged me that her phone has gone out of battery. So we end this session here. Thank you so much. Let's meet next Friday, unless there's a change, from 7 to 9:30.
Thank you, madam.
Sure, ma'am. Thank you.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you, everybody.